Welcome, I am Dr. Paul Frank, Medical Director at Fremont Rydell Health Group. You're about to view the 10 Signs of Vitality, an educational program designed to train clinicians to thoroughly evaluate and rapidly identify patients at risk for cardiovascular, respiratory, or neurologic decompensation. This program empowers bedside clinicians to identify critical illness earlier and rapidly mobilize appropriate hospital resources, thereby decreasing hospital morbidity, mortality, and unexpected cardiac arrest. It also is designed to improve staff communication regarding patient assessment and accurately identifies triggers to mobilize a rapid response team. This program will be presented by Sue Henderson, nurse practitioner and critical care educator at Fremont Rydell Health Group, and Dr. Frank Sabat, director of Kritikus Foundation and medical director of critical care services at Fremont Rydell Health Group. Please join us now for the 10 Signs of Vitality.
I'm Frank Sabat.
And I'm Sue Henderson.
And together we're going to present to you the 10 Signs of Vitality, a comprehensive educational program for clinicians to improve earlier recognition of critical illness.
The 10 signs of vitality are the essential physiologic signs of life. They're the essential assessment for treatment of critical illness. And early assessment and intervention will, we believe, decrease morbidity and mortality and reduce unexpected cardiac arrests. The classic vital signs are temperature, pulse, blood pressure, and respirations. In 1995, the American Pain Society added pain as the 5th vital sign. Today we're going to add 5 more: level of consciousness, oxygen saturation, urine output, capillary refill, and central venous saturation. Included in this is being able to communicate this assessment to a physician using SBAR communication. That involves the situation, the patient's background, the assessment information incorporating the 10 signs of vitality, and the recommendation for treatment. And this involves having the patient's chart available for information and orders.
I'd like to add to that as a practicing clinician that when a nurse calls me and starts giving me information about the location of the patient, who the primary care physician is, and when the patient was admitted, if I don't know that they're calling for hypotension or hypokalemia, I will forget most of the information the nurse tells me because I cannot focus on what information is important. So, as Sue has described, explaining the situation, why are you calling first? I'm calling for hypotension or hypoxia, or I'm concerned about the patient and I don't really know what's wrong with them, and they're a patient of Dr. So-and-so's at such location, helps the clinician frame the information that you give them in a way that they can dissect that information out and apply it to the situation in which you're calling.
These are the complete 10 signs of vitality that we're going to talk about today.
Heart rate and pulse are actually different. Heart rate is the number of beats or cardiac contractions per minute. Pulse also reflects that number, but in addition, it reflects the quality of the stroke volume, the character of how strong the palpation of the pulse actually is. And so we use them interchangeably, but they're not identical, and it's important to make that distinction. In terms of heart rate, any heart rate below 50 or above 100 is a significant abnormality and should trigger further assessment as to what's going on with the patient. In terms of feeling the pulse, you may have a pulse of 60 or 70, or a heart rate of that, but when you feel the pulse, it's very weak or irregular, or you can't feel it at all, and that's very important information in addition to the rate. You also need to measure for a substantial period of time, particularly with an irregular pulse, because unless you do it for 15 seconds or so, you may not get a true measurement of what the rate is for a minute.
And it's important to note what the patient's baseline heart rate is.
An irregular pulse requires that you determine if the rate that you're determining by either EKG or by palpation or by auscultation are one and the same. They can be different. The difference is reflected as the pulse deficit. So if you have a very fast heart rate, particularly one that's irregular, such as an atrial fibrillation, you may have so little time for cardiac filling that you have a heartbeat, and it's calculated as part of the heart rate, but you actually don't get a pulse with it. You get very little effective forward flow. As a result, it's important to note the difference between the heart rate that you're determining apically and the pulse that you're actually able to palpate peripherally. This occurs in rapid atrial fibrillation and may also occur with premature atrial contractions or premature ventricular contractions. Now here is an example of an electrocardiogram or rhythm strip in which you see underneath it an arterial waveform. And here you can see where the R to R intervals, or the time for cardiac filling, is long, and therefore the arterial waveform indicates a fairly strong pulse. The next beat reflects a short R to R interval, less time for cardiac filling, and a weaker pulse. The strength of the pulse is really the difference between the stroke volumes. So if you've got a blood pressure of 130/40, you're going to have a very strong pulse because of that difference, and you feel that pulse wave coming down the artery as you have your hand on the radial artery or the groin. However, if the difference between the systolic pressure and the diastolic pressure is low or small, such as a blood pressure of 95/70, where the difference is only 15, it may be difficult to feel a pulse even though you may have a borderline pressure. In certain situations, it may be necessary to determine the pulse in another method other than palpation. Particularly if you can't feel a peripheral pulse, always go to the central pulse. And my clinical practice is, because it's very convenient, because most patients are laying on their back, that you can just very quickly go to the groin and feel a femoral pulse. I find it a little more difficult to try to localize the carotid, but some people are very good at that. So either carotid or femoral pulse. If you don't feel that well, then get a Doppler out, and at least you can then start to hear the flow and determine by the sound quality whether you have significant flow or you may be in a very low flow state where you barely hear any sound at all. So an easily palpable pulse indicates an adequate stroke volume or a high stroke volume. A weak pulse is going to indicate a low stroke volume and or loss of vascular tone. Now, we're intermingling pulse and heart rate, and now we're going to talk specifically about heart rate, of which the most common form in the hospital setting is sinus tachycardia. It's a physiologic response to increased cardiac demand. Fever, low circulating blood volume due to dehydration, bleeding, anemia, increased work of breathing for whatever reason, lung disease or lack of oxygen in the blood. It also can be a response to inflammation, particularly inflammation which is having a systemic effect. So if you have pancreatitis or you have a burn injury or trauma, if there's enough inflammation in those tissues that's spilling over into the entire body, it will increase the heart rate. And this is known as systemic inflammatory response. This is an important concept. SIRS, or systemic inflammatory response syndrome, means that whatever's going on is having a systemic effect and frequently will lead to other problems and complications. Sepsis is a specific type of systemic inflammatory response that is due to infection. So if you had a pneumonia where the effect was spilling over into the entire body, then you would have SIRS in relationship to the cause being pneumonia. Other causes of increased heart rate, catecholamines. We have our own. You may be having pain, you may be having anxiety, and as a result your adrenal glands and sympathetic nervous system are cranking out more catecholamines. It may be exogenous. We may be delivering catecholamines to the patient in the form of dopamine or dobutamine or others. We may have a problem in older patients with a sinus node, in which case it's diseased, and instead of maintaining a normal rhythm, will maintain a fast and rapid, although sinus rhythm. Overactive thyroid. These are all causes of sinus tachycardia. The importance of this is that sinus tachycardia is always a significant abnormality that needs to be pursued as the cause. You don't ever want to just go in and treat the heart rate without determining the underlying cause. It's the most common increase in heart rate. It's always regular. And one of the hallmarks, because sometimes you can confuse sinus tachycardia with other rhythms, one of the hallmarks is, besides the fact that it's narrow complex, and that's important, is that it increases or decreases either gradually in response to either the treatment i.e. if you think it's hypovolemia and you give fluid and you get a heart rate of 130, it will slowly come down to 125 and 120 and so forth. And or if the patient is deteriorating, your therapy is not working, it tends to go up gradually. So maybe 5 minutes later you're at 125, another 5 minutes later you're at 135. You do not get abrupt changes where all of a sudden you're going from 110 to 150 unless you have a massive event like a massive pulmonary embolus. So when you see rapid increases in the rhythm, you have to be concerned that that might reflect something else. The most important thing is do not treat the sinus tachycardia pharmacologically. Don't put the patient on beta blockers. Don't try to get the heart rate down without understanding why and address the underlying cause. And then the heart rate should respond to you treating their hypoxia, their hypovolemia, their anxiety, or their pain. The exception to this, and this is a very important exception, if you have active coronary disease causing the tachycardia, patients having chest pain, EKG changes, and you know that that's the cause of the tachycardia, you have to treat the increased heart rate because it's going to make the coronary artery ischemia worse by increasing oxygen demand from the myocardium. So that's the one exception where you come in and do treat sinus tachycardia.
Supraventricular tachycardias or narrow complex tachycardias can be one of many varieties, but we're focusing on sinus, paroxysmal SVT, or atrial flutter. These can be very difficult to distinguish at rates greater than 130, but it's important to know what the underlying rhythm is. One way of diagnosing this is to administer adenosine to a monitored patient. Normally we give 6 milligrams and then follow with 12 milligrams, which can be repeated. And what this does is actually arrest the heart rate for a very brief period of time. And then as the rhythm returns, initially at a slower rate, and then it normally will go right back up to what the baseline rate had been, you're able to distinguish the P waves and where they're originating from, or if there are actually any visible P waves. Interventions for tachycardias involve assessing the other signs of vitality in an effort to discover what the underlying cause is. Again, sinus tachycardia should not be treated until the underlying cause has at least been identified and hopefully treated. Paroxysmal SVT, atrial flutter, and atrial fibrillation with a fast rate should be distinguished from sinus and then treated.
I'd like to add is that when you looked at that rhythm strip, adenosine was given to that patient, and you saw the R to R interval get large, and as a result, you saw the underlying flutter waves. There is some reluctance because of the concern of adenosine producing a very slow, effective stroke volume or ventricular contraction. I can tell you that concern is unfounded. I have used adenosine, and many physicians have used adenosine in their career. I have never seen a patient get into trouble with adenosine, and I've identified atrial fibrillation or atrial flutter many times when I thought it was sinus. So it's very important when you have a regular tachycardia at a rate of 150 or 140, and you're not sure what it is, and the patient's in a monitored area, giving them adenosine is safe and it is very diagnostic.
Atrial fibrillation is an irregular tachycardia, and it's an irregularly irregular rhythm. At rates greater than 100 beats per minute, you get a significant pulse deficit. These patients are at increased risk of arterial embolization, and this is normally seen with stroke, ischemic bowel, or extremities. And they're at increased risk because the atria isn't fully emptying, it's just trembling. And so it's forming clots along the walls of the atria, which can be released erratically. So this rate needs to be treated and anticoagulation considered. Bradycardia, we don't always think of this as a problem. Significant bradycardia is considered to be a heart rate less than 50 beats per minute in non-athletes. And Dr. Sabat was telling me Lance Armstrong's resting heart rate is in the 20s, but I don't remember what the
my hero
yes.
Basically has a resting heart rate of around 25, and I'm told that if you get too close to him, you can actually hear the blood going out per beat. So he has an incredible stroke volume. So he's ejecting 150 cc's per beat, where you and I are ejecting 60 or 70 cc's per beat.
But in the rest of us, some causes of bradycardia can be sick sinus syndrome, and we see this especially in the elderly, beta blockers, coronary ischemia, hypothermia, hyperkalemia, or digoxin. Bradycardia does not need to be treated unless the patient's symptomatic. Some signs of symptoms or common symptoms seen with bradycardia are syncope, lightheadedness, hypotension, oliguria, or any other sign of poor perfusion. The treatment of symptomatic bradycardia is withdrawal of the beta blocker or digoxin if the patient's on those and you've determined that that's the cause. If the patient needs further treatment, they can receive atropine. Dopamine treats the patient in two ways. It elevates their blood pressure, but it also can increase, or will increase their heart rate. And then if you need further intervention, you can use an external or internal pacemaker.
Temperature is a vital sign which frequently has phone calls coming to the physician in the middle of the night. So this is why I asked Sue, could I present this vital sign?
He's passionate about it.
The normal temperature, 97 to 99.5 or 36 to 37.5 Celsius, with a 1 degree or 0.5 degree respectively increase, either Fahrenheit or Celsius if you measure a core temperature, i.e. rectal, has a range that going from 98 to 100.5 or 36 to 38. When we're measuring temperature, we would like to do the most accurate measurement we can. Axillary is the least accurate for two reasons. One is it may reflect skin perfusion as opposed to what the patient's temperature is. Secondly, it's always lower than core, always. So if I have a temperature of 99 axillary, is it 100? Is it 101? You don't really know unless you check both. If you check both and you document what the difference is between the two and it's consistent, that would be the only situation in which I would think axillary would be of value. Otherwise, I think axillary temperature should not be used as a measurement of patient's temperature. And we should always be doing either oral, and if you have an endotracheal tube in place, I even have some concerns about that because the humidified heated air coming through the tube and in the mouth is going to have an effect on their temperature. But in a patient who can close their mouth, I think oral is very good. In those who can't, or you don't think oral is accurate, then we need rectal Foley or pulmonary artery catheter temperatures. And if you happen to have a PA catheter, that's a very easy way to just take it off the monitor, but a Foley temp or a rectal temp. Tympanic has gained a lot of interest because it's very convenient. And I don't know what the experience here is in the audience, but the problem is that sometimes it's variable and you don't know the situations in which it's accurate and the situations in which you don't. So tympanic, I don't think has really caught on yet as a standard measurement of temperature, at least in adults. So if you have a low-grade temp, less than 101, but a greater than 100.5, is the problem inflammation from surgery or pancreatitis, atelectasis, or infection? Well, you don't really know, but it's important to take in the differential, that it can be due to inflammatory processes other than infection. And atelectasis is an important one because it has sequelae if not treated. A temperature greater than 101, although can be seen in other disorders other than infection, frequently is seen in infection. And greater than 104.5 is a problem regardless of the cause because now you're starting to approach temperatures in which you become concerned about inducing seizures, delirium, high fluid losses for the patient, etc. Now, temperature varies throughout the day. And normally, it will go up 2 degrees from your temperature in the morning to your temperature in the evening, which is why the night shift is the one always calling the physician with the fever. Because if they were 100 in the morning, they're now 102 at night. Well, did they not have an infection in the morning? Yes, they did. But it's this diurnal normal variation that is responsible for recognizing the fever at night. The elevation of the fever is kind of an interesting biologic response. It turns out the monocytes are the first responders. You get a splinter, you get an infection, you get a burn or a blister. The monocytes are the macrophages that move out of the blood vessels right to the tissues and respond immediately to the foreign object or foreign body. They then release various cytokines that go right to the hypothalamus and raise the temp. Now, the biology and our evolution would suggest that maybe this response has some biological value. Lots of things that cause monocytes to release their cytokines are atelectasis, the wound of surgery or the insult of surgery, inflammation within other organs like pancreatitis, trauma, and of course infection is the one that we become most concerned about. Fever due to infection and atelectasis need to be diagnosed because it has therapeutic implications, whether you want to give incentive spirometry, get the patient out of bed, IPPB. And by the way, the single best therapy for atelectasis always is getting the patient up and moving them. It turns out that fever, in fact, is a beneficial response to infection. It increases microbial killing due to improved white cell function, increased antibody production, and decreased microbial growth. Turns out that bacteria, once the temperature gets up to a certain level, actually don't do as well. There are actually studies published which show that if you treat the fever, the infection lasts longer. And this was some study done in pediatrics with viral infections. So a call to the physician to treat the fever may actually be harming the patient. Not that the call is harming the patient, but the therapy that you're eliciting. And I will tell you at 3 o'clock in the morning, when you call me for a Tylenol order, it is far easier to say, fine, in the conversation, doctor was very polite, or you call me at 3 o'clock in the morning and I start giving you this explanation, in which case I'm getting grumpy, and my conversation may not come across quite the same way as it would in 1 o'clock in the afternoon. So it's important, obviously, to document the method of measurement, and you want to use the most accurate method. Any significant change in the temperature, of course, has got to trigger an assessment, and it's going to trigger a call because it's a change in the temperature. Okay? Not because you want Tylenol, but because the temperature's changed and you need to help the clinicians figure out why and what to do about it. So you're going to assess, is this infection interfering with their brain, or is that the source? Do they have meningitis? So you're going to assess their level of consciousness. Is it coming from the lung, which is one of the most common sources? Do they have new sputum production? Do they have a cough? Is it coming from the abdomen? And in the hospital, new onset of diarrhea and fever has got to trigger everybody to think about C. diff colitis. So reporting to the clinician that yes, they have a new fever, and yes, they have a new problem, they've got some abdominal discomfort and they got diarrhea, will really help the clinician help you get what it's needed for your patient. Invasive lines are another common source of fever, infection, and morbidity in hospitals. We want to get the lines out as soon as possible, the Foley catheters out as soon as possible. And it's important when you communicate a new fever is, how long has that central line been in? And the nurse that calls me and says, Dr. Sabat, your patient has a temperature of 102, they don't have a headache, their neck is not rigid, they don't have a cough, their lungs sound fine, they don't have any belly pain, they're not having any diarrhea, but that central line's been in for 15 days. That nurse gets a hug. Because that's given me exactly the information I need to give the patient what they need, give them one dose of Vanco, get that line out, culture the tip, can we get peripheral access? Does the patient need pan cultures? And do they need to be reassessed by the physician? And this is why I wanted to do this section of the presentation. Fever does not need to be treated unless it is compromising the patient. So if you have coronary ischemia, if you've had a stroke or central nervous system surgery, a brain tumor, increase in intracranial pressure, head trauma, you need to treat the fever because the outcomes are far worse in those patients if you allow them to have even low-grade fevers. So we're very aggressive at lowering the temperature to normal, and in some cases below normal. A person with a seizure disorder or temperature 104, all these situations you call me and you say, can we treat the fever? My patient is having angina, or my patient just had a stroke, or my patient has had seizures. I'm going to thank you very much for the phone call, and yes, I want aggressive treatment. But if you don't have those things, don't ask me to lower the temperature. Give me the information I need to figure out why they have the temperature and what we're going to do about it.
Hypothermia. Some of the physiologic significance of hypothermia is that we see a decreased blood flow and decreased cardiac output. It decreases the metabolic rate, It causes vasoconstriction, which can then lead to peripheral ischemic tissue damage, and it results in a prolonged PT, PTT, and bleeding. Hypothermia is usually accidental or therapeutic. Some of the issues we have in patients who are hypothermic is we see refractory ventricular tachycardias at temperatures of less than or equal to 28 degrees Celsius. And actually, this is what the research reports, but we've actually seen these arrhythmias in patients who are cooled down to even 32 degrees. Atrial arrhythmias can be seen at temperatures of less than or equal to 34 degrees Celsius. And generally, hypothermia is of little consequence until the patient's cooled below 36 degrees Celsius. We do see a higher rate of infection in patients who have been cooled in the operating room or patients who have been treated with therapeutic hypothermia. Therapeutic hypothermia has been used in the treatment of post-cardiac arrest patients in order to reduce the central nervous system injury that they may have suffered due to an anoxic injury. It's also used in cardiac and neurosurgery for cardio and neuroprotection, but it has the same risk factors that are associated with accidental hypothermia. So these patients have the same risk of bleeding and the same increased risk of infection. The treatment of unintentional hypothermia is passive therapy for temperatures that are greater than 35 but less than 36 degrees. We generally just let the room warm them. If patients' temperatures drop beneath 35 degrees, we generally just use a warming blanket or a bear hugger. If the temperature goes beneath 33 degrees Celsius, we still use the bear hugger, the warming blanket, but we also can warm their IV fluids or give them warm blood. We can also increase the temperature to maximum on the humidifier on the ventilator. And then in the most severe cases, we can use hemodialysis or bypass in order to rewarm the patient.
I'd like to add, we had to what Sue said, in that we had a patient here in the hospital whose temperature got down to 32 degrees.
We were cooling them therapeutically. It didn't just happen.
Correct. And they did go into refractory ventricular tachycardia. So although we say 28 degrees is where ventricular tachycardia occurs, I've seen it at warmer temperatures. So I think that once you start to get below 33 degrees, your anxiety level needs to increase.
Well, and when we say refractory, we mean that even the normal medications we give at that point for VTAC are ineffective. Really, none of the treatments we normally would use for those arrhythmias work in those patients. Okay, respiratory rate. Normal is 12 to 15 breaths per minute. It's considered significantly abnormal at rates less than 8 or greater than 20 breaths per minute. The normal tidal volume, or the amount of breath the patient takes with each breath, is 500 cc's of air in the average size patient. And the patient's minute ventilation, or the amount of air they move in 1 minute, is 6 to 8 liters of air per minute. These are just averages. They change based on the size of the patient. Respiratory rate is the most inaccurately charted vital sign. It needs to be measured for 1 full minute, and there are significant differences found in rates that have been measured for 15 seconds versus rates that have been measured for a full minute. If you have difficulty accurately observing the rate, it is helpful to put your hand on the patient's chest, particularly if they're having shallow respirations. And if necessary, you can use a stethoscope so that you can hear the respirations. Tachypnea is commonly defined as an increase in respiratory rate greater than 20 breaths per minute. And some causes of tachypnea are an increased dead space or COPD, patients that have PEs, hypoxia, primary central nervous system disorders, or patients who have greater oxygen demands due to infection or sepsis.
Tachypnea and the other physiological and clinical consequences are very important. And I think that tachypnea is one of the most sensitive indicators of serious or critical illness. It's not very specific, but it's incredibly sensitive. And I think, as Sue mentioned, that it's probably one of the most inaccurately charted vital signs is because there is a lack of appreciation that when the respiratory is 18 versus 24 in somebody who has been 18 all along and now has gone up to 24 and sustained at 24 or 25, that may not mean much because it's not specific, but it could mean early onset of sepsis, early onset of shock, early onset of GI bleeding, it is an incredibly sensitive indicator of impending critical illness. And I think it's our lack of appreciation of that and the fact that we think that if a respiratory rate is 6 or 4 or a respiratory rate's 36 or 40, those are the important respiratory rates to be charting. And anything in between can just be put on the chart and it doesn't make any difference. But that's not correct. And I can tell you that if a nurse calls me up and says, I don't really know what's wrong with the patient, but I'm concerned, the first question I ask is, what's the respiratory rate? And if the vital signs are fine and the respiratory rate's 18, my anxiety level goes down and I continue to ask questions. If the nurse says the respiratory rate's 26 and the rest of the vital signs are okay, my anxiety level increases. So the correct charting of what the true respiratory rate is very important. The causes and physiologic significance, anxiety or pain, it can be cardiac disease. Low cardiac output will cause tachypnea, even if you don't have pulmonary edema. But if you do have pulmonary edema because blood is backing up into the lungs, of course, you're going to get tachypnic for 2 reasons. Hypotension and shock, the beginning of a metabolic acidosis, whether it's diabetic ketoacidosis, lactic acidosis due to hypoperfusion. And as I said, it's incredibly sensitive of critical illness. It's just not specific. It's the SED rate of critical illness. The assessment, besides looking at the rate, you need to figure out, is the patient taking good deep breaths, or they can't and they're shallow? Is the respiratory pattern regular or not? And how do the lungs sound? Is there air moving in and out of them? Is there wheezing? So tachypnea should be an indicator to perform the other 9 signs of vitality to help you sort out what's really going on with this patient. Plus or minus a blood gas depending upon the clinical situation, how bad the tachypnea is and what the physician feels.
Slow breathing. It's considered a problem when the respiratory rate drops to a rate less than 8, and you need to consider whether this is being caused by a central nervous system depression. This can be due to narcotics, sedatives, carbon dioxide retention and narcosis, or brainstem compression, and this is normally seen with dilation of pupils. Interventions. It's important to auscultate the lungs and listen for sounds bilaterally to rule out perhaps a pneumo. Expiratory wheezes indicate a narrowing of the airways. Rhonchi are caused by retained secretions. And then decreased inspiratory breath sounds, which can be caused by atelectasis, pleural effusion, or a pneumothorax.
Blood pressure has a range, as you see up there, with normal being 120/70, but up to 140/90 is considered normal, and as low as 90/60 for many patients may be normal, particularly thin and athletic individuals, with a range on the mean pressure of 106/70. Significant hypotension is always an issue that needs to be addressed until proven that it's not significant. So if you've got a mean arterial pressure of less than 60 or a systolic pressure of less than 90, that is a red flag requiring you to do further assessment. If a patient normally runs a blood pressure of 90, then of course it's a little different and you're going to have to see how much has dropped from baseline. Make sure your measurement is correct. Arm size and cuff size are very important. So if you have somebody who has a huge arm and a little cuff, you could put 180 millimeters of pressure in that cuff, and that 180 millimeters of pressure will not get transmitted to that artery because the arm is huge and the cuff is small. And so you will get a falsely elevated pressure because the pressure it'll take to occlude that artery may be 200, whereas the pressure in the artery may only be 140, and it's the fact that the cuff is too small for the arm and not transmitting all of that pressure directly to the artery. The converse is true. If you have too large of a cuff on too small of an arm, you may get a falsely low blood pressure. The single best measurement for blood pressure is an arterial line. The next best measurement's an arterial line, the next best measurement's an arterial line, and the next best measurement's an arterial line, period. After that, the next best measurement is a Doppler. With a Doppler, you don't get pressure, you only get flow. But you can take a cuff and you can blow it up at the point that flow stops, or if you're letting the cuff down, at the point that flow starts, that you hear in the Doppler is the systolic pressure. You can't get a mean, you can't get a diastolic, because all you will do is to continue to hear flow down to 0. But it is an incredibly accurate measurement of systolic pressure. Stethoscope with auscultation and palpation is next, and the worst way to measure a blood pressure is a Dynamap, which happens to be the most common way we measure blood pressure. That's fine for the stable patient. You're measuring their blood pressure with a Dynamap, you have a sense that it truly reflects what their blood pressure is, and you have a trend over time, and the patient's doing fine. In the emergency room, in the ICU, or on the floor, when a patient's clinical status changes, let's say their urine output drops or they get altered mental status, they're tachypnic and diaphoretic, I will tell you that about 35 to 50% of the time, the Dynamap pressure is wrong. And I don't know how many times I've come into the emergency room and the blood pressure is being recorded as 100 or 110, and I either get the A line in or I say, please check a Doppler blood pressure, and that's always triggered by my putting the hand on the groin, barely able to feel a pulse. And blood pressure is 60 systolic. And everybody says, oh my God. Well, it was always 60. So in a sick patient where you are getting anxious about the patient because of the way they look, it would be very important to double check. Now, if it turns out the Dynamap's fine, you do a Doppler and they're the same, bingo, you're home. Keep using the Dynamap. But many times you'll find out that the patient's pressure is not what you're getting. It's also important to understand the concept of pressure versus flow, because you need both to live. You know, a trauma surgeon once came up to me and he said, you know, Frank, the only thing you need to do to keep somebody alive is to keep the air going in and out and the blood go round and round. And if you do that, everything's fine. So if you have enough pressure, but you don't have flow, your vital organs are going to die, even though you got a good blood pressure. And that happens in CPR. If you have an A line in place and you're doing chest compressions, I can generate pressures of 110. If you get somebody who's the size of Brad, I bet he can get a systolic of 180 in CPR. Okay? But all you're doing is creating pressure. It's like clamping off the artery, and you have incredibly high pressure, but there's no flow. It's not going anywhere. The converse is true. You may have a high flow state in which you have very little pressure. This could be in sepsis, where you've given a lot of fluid, you resuscitated the patient, you have lots of preload in the heart, and you have a high flow state, but you don't have any pressure. So you got a systolic pressure of 60 and a very high cardiac output of 8 or 10 liters. So you need both. You need a pressure head to get blood to the organs, and you need adequate flow. And we're going to spend some time on the signs of vitality later to tell you how to assess flow. I know that a number of the nurses who are not in critical care, and the floor nurses, the emergency room nurses, are going to wonder, why in the world are we going to do math in this class? Why do we need to know that the mean arterial pressure is the cardiac output times the systemic vascular resistance? I hope at the end of this talk that when you're taking a shower, that this is the first thing that comes to your head. Mean arterial pressure is equal to cardiac output times systemic vascular resistance. The fact that you divide by 70 to make the math comes out is relatively inconsequential. I don't care if you can get the right number. What I care about is you understand the concept. So here are some examples to help that. I've got a mean arterial pressure of 85. We know that that's normal. I got a cardiac output, in this particular example at the top, of 5 liters. That's a pretty average cardiac output, 5 liters per minute. The heart's moving the blood round and round. I don't expect you to understand what dynes per second is or what 1200 means, other than that's just a measurement of the resistance. But what you need to know is that in the next example, my blood pressure has actually gone up a little bit. My cardiac output has almost doubled, and my resistance has nearly dropped in half. And although my blood pressure looks fine, this is a markedly abnormal physiologic state in which this patient is probably septic. And they are compensating because the resistance is dropping, and the way they're compensating is increasing their cardiac output to maintain pressure. So understanding that cardiac output times resistance is what pressure is allows you to understand that relationship. The next example of a normal blood pressure is somebody who's in cardiogenic shock. How are they maintaining a normal blood pressure? They've nearly doubled their resistance. And this is common. You see people coming in the emergency room all the time in cardiogenic shock. They got an adequate blood pressure. And how do you know that their resistance is sky high? Because the first dose of morphine, their blood pressure's in the toilet. because you got rid of their endogenous catecholamines and allowed their resistance, which they were clamped down on purpose to maintain blood pressure, is now gone. And so the resistance goes from 2,000 to 800, and next thing is you got a blood pressure of 60. Well, you didn't affect the heart, you affected the resistance.
One thing I want to point out on this also is, if you had seen these last two patients in the emergency room and you were only using the traditional 5 vital signs, you could have missed it. But if you would expand your assessment to include the last 5 that we're talking about today, you wouldn't miss it. It would be picked up in the last 5 that we're introducing today.
Now, why is mean arterial pressure a number that's so important? It's directly proportional to coronary artery perfusion. So my hero, Lance Armstrong, will go into cardiogenic shock if I drop his mean arterial pressure to 40 or 50. His coronaries aren't being perfused. He's got the best heart on the planet, but it needs blood. And I have seen athletes, I've taken an athlete to the cath lab because they were in profound shock and had ST segment elevation, and I thought it was coronary disease. Coronaries were whistle clean and there was no spasm. Their blood pressure was so low they weren't perfusing their heart. As soon as we got the blood pressure up, and that's why we use Levofed a lot, just like a mask suit, you gotta perfuse the coronaries. Once you perfuse the coronaries and get the heart back online, you got something to work with. If you can't get the heart online because your mean arterial pressure is too low, the ball game's over. All shock leads to cardiogenic shock. And this shows you the shoulder here is 60. So as the pressure gets below 60, coronary artery blood flow drops off dramatically. Conversely, you don't get much bang for your buck. So we tend to keep the mean arterial pressure in somebody who we're resuscitating at about 70, where we get the most bang for our buck without increasing myocardial oxygen demand. The importance of tissue perfusion cannot be emphasized, but it's not equal to all tissues. And as you get hypotensive, the first organ that will be sacrificed are the extremities, which is last on the slide. And that doesn't really make a whole lot of difference because most of the time the extremities can tolerate lack of blood flow and we have time, and seldom do we lose digits or extremities unless we have peripheral vascular disease. The coronaries will do everything they can to maintain perfusion unless we take that away from them, or they just can't, in which case we need to do something about it. And the brain is next in line. What's important is the abdomen. The abdomen, like the extremities, will sacrifice blood and divert all blood away to try to perfuse the coronaries. And when we die of hypoperfusion, it's usually not a brain death. It's very unusual to get brain injury from shock unless you arrest. And it's very unusual to get extremity injury from shock. But why we die is our small bowel or our colon or our gallbladder or our liver has gone south because we didn't perfuse it.
Okay, so it's important to understand what your goal is for the mean arterial pressure. And from a nursing perspective, if you don't know what the goal is, you need to make sure you clarify that with the physician. Then, if your mean arterial pressure falls beneath that goal, you need to start considering why it's fallen. Is it due to a volume deficit that's caused a decrease in your cardiac output? Is it primarily a cardiac problem or a pump failure, something like cardiogenic shock? Or is it due to a decreased vascular resistance, which we see in septic patients? And it doesn't necessarily have to be one of these independent of the others. It can easily be all 3 or 2 of the 3. So addressing is the problem volume related? In order to figure this out, you need to review the patient's previous 24 to 48 hour intake and output record, and it needs to be an accurate record. Then you need to be able to trend the patient's weight to see if they're gaining weight. You also need to look for losses, diarrhea, vomiting, NG output, output from drains. Has the patient had a sustained fever so that there's an insensible fluid loss that we really aren't capturing in the I&Os, but we know they've been running a fever for days? Is this reflected in the CVP if you have the access to monitor the CVP? And then have they suffered any kind of loss of blood, a drop, slowly maybe, of the hemoglobin? Once you've decided or have ruled out or ruled in the volume status issue, then it's time to address the cardiac output and function. Do they have an adequate normal capillary refill, which we'll address in a little bit? Is their urinary output normal? Is the 12-lead EKG showing you any clues, any ischemia? Is their BNP or troponin levels elevated? Have they had an echocardiogram? And if they have, what's the ejection fraction? And has it changed from the baseline that they may have had a couple years ago? And then are they on any medications that may be depressing the pump, something like a beta blocker? Once you've addressed both of those, then it's time to look at the vascular resistance. You need to rule out sepsis or if the patient's suffering from systemic inflammatory response syndrome. And these are all things that will point you towards a SIRS diagnosis. Does the patient have a fever? Are they tachypnic? Are they tachycardic? Do they show an elevation in the WBCs or an elevation in the bands or the immature white blood cells? And are they showing any evidence of organ dysfunction? And then after that, could this possibly be a medication issue? Have they received perhaps too much in the way of an antihypertensive or a narcotic?
The hypotension aspect of this presentation, we are including SIRS, and although you might say, well, this is not directly related to hypotension, it's such an important concept that we wanted to include it. There is a national movement to identify patients who have systemic inflammatory response due to infection because that's sepsis. The mortality is high, the morbidity is high, and it's part of the Surviving Sepsis campaign, the Institute of Health Improvement, and other agencies to recognize this entity and address it. So again, we're going to reiterate, if you've got fever, tachypnea, tachycardia, elevated white counter, elevated bands, you have SIRS. If it's due to an infection, you have sepsis. And if you have any organ dysfunction associated with sepsis in SIRS, your risk of death is very high, and therefore you need to identify it. And organ dysfunction is very simple. It's cardiovascular. If you've got a low blood pressure, if you drop the urine output of the creatinine's going up, the kidneys are south. If you're requiring increasing amounts of oxygen and or your O2 sats are dropping, the lungs have a problem. If your bilirubin's going up, liver may very well be a problem, and hematologic failure is defined as a platelet count of less than 100,000. Now, if you identify SIRS, then you're going to look around. Is the SIRS just due to pancreatitis or is it due to infection? Once you've identified it's due to infection, you're going to look, do they have any evidence of organ perfusion? If they do, this patient is at very, very high risk and is going to require more attention and require you to do a thorough assessment of the full 10 signs of vitality.
So once you've completed your assessment and you're going to call the physician because you do have a low blood pressure, we're asking you to expand the information you're giving the physician. Instead of just calling and saying, my patient's blood pressure is low, we want you to talk about the assessment you've done, that you've assessed the patient's volume status and found it to be lacking, you've assessed the patient's cardiac function and found it to be lacking, or that you've looked at the patient's vascular resistance from the assessment tools that you have, and you've come up with a plan. You've come up with an idea of why your patient's suffering from this low blood pressure. And again, it goes right back to the same formula we were talking to you about before, that the mean arterial pressure is a function of the cardiac output and the patient's systemic vascular resistance, which you've just done a complete assessment on with what you have available to you with the 10 signs of vitality. The treatment plan that you can expect would be a fluid bolus of 500 cc's for hypovolemia, and that may need to be repeated. Withdrawal of any of the offending medications that you may have assessed the patients on it and may be having a bit too much of. Narcan for a narcotic-induced hypotension, or Ramazicon for benzodiazepine-induced hypotension. And then possibly the need for atropine or pacing for bradycardia if the patient's symptomatic, and possibly pressors for a low SVR or for cardiac causes.
Hypertension is defined as a systolic greater than 140 and a diastolic greater than 90, a mean greater than 106. However, clinically significant hypertension in the hospital. So we have to distinguish. It takes weeks, months, years for hypertension less than 180, diastolics of 100 or less, to do end organ damage. It's not that it doesn't need to be addressed, but it's not an emergency, unless the patient has comorbidities that I'm going to talk about. But once you start to get systolics above 180 and diastolics above 100, that is the situation in which the phone call in the middle of the night may very well be appropriate. If it's new and the physicians have not identified that as an issue. However, a blood pressure of 170 and a systolic of 90, and the patient doesn't have, if we go on to the next slide, one of these comorbidities, the phone call can wait, or you can wait until the physician comes in the next morning. Because if you don't have active coronary ischemia, or you don't have a hole in an artery, or you don't happen to have a really bad pump where raising the pressure is going to put a bigger strain on the pump and cause the blood to back up into the lungs and resulting in the last comorbid state of pulmonary edema, treating the blood pressure by a day or a week or 2 or 3 or 6 weeks later is going to make very little difference in the care of the patient. But if you have one of these, it's going to make a huge difference. If you take the blood pressure from 140 or 150 down to 110 and you have a decreased ejection fraction, you're going to improve that dramatically. If you're having angina, you may very well decrease it. If you have active bleeding, for sure you're going to slow it down. So you don't want a hypertensive patient in active bleeding for sure. And you're going to get them out of pulmonary edema faster at a blood pressure of 110 or 120 than you are at 150 or 160. The exception, and this is a very important exception, and we've seen patients, we've had arterial lines in, they've been in the ICU, they come in, they've got some slurred speech, their CT scan does not show a bleed, we think it might be a lacunar infarct, we're not sure, or it might be a middle cerebral artery infarct, they've got some weakness on their side, and their blood pressure is 210 over 110. What are you going to do? Well, if you give them a beta blocker and some procardia, you may make their stroke much worse, much worse. And I've had the opportunity, because I've had an A-line in place, to start some nitroprusside, and I dropped the blood pressure to 180, and the speech deficit got much worse. And I turned off my drip and let the blood pressure auto-regulate and go up. Now, yes, that blood pressure is high, and that puts that patient at risk for an acute complication. But they didn't have bleeding, they didn't have angina, they didn't have pulmonary edema. And therefore, I thought I could allow them to have what normally would be a treated range of hypertension, to get perfusion to the brain, recover the brain. Once the brain is recovered, then address the hypertension. Any lowering of blood pressure in the setting of cerebral ischemia, whether it's a stroke or a head injury, has to be done in a monitored situation very carefully. And many times, we will opt not to treat the high blood pressure.
Okay, our next sign of vitality is pain. Our goal in pain management is to eliminate suffering, but it may not be appropriate in all cases to eliminate all pain. During the recovery phase, it's better to have a functioning brain than to have no pain. There are 3 different pathways that we've identified for pain management. The first is life support or acute injury phase pathway, and in this pathway the goal is mild to no pain. The second pathway is the recovery pathway, and in this one it's maybe necessary to allow the patient to have some degree of pain in order to have them be able to participate in their therapy, whether that's physical therapy, coughing and deep breathing, participating in ambulation, and those types of things. And in the comfort pathway, and this is generally end-of-life type patients, the goal is absolutely no pain. Measuring pain is very subjective and sometimes can be very difficult. Depression and anxiety may contribute to pain, and the perceptions of the pain providers may color their pain assessment. Pain has a very important physiologic significance and physiologic function, and that's to direct the patient and the caregivers to avoid injury to the patient. The inability of a patient to feel pain can lead to injury. We see this in patients with diabetic neuropathies who have foot injuries that they're unaware of, and sometimes those injuries progress to pretty significant infections before they're even detected. Pain is one of the most important symptoms because it directs clinicians to where the problem exists and what the diagnosis may be. Pain is an important initial assessment tool, and this can be a problem because if the pain is eliminated before the assessment is completed, an incomplete clinical picture can result. Chronic pain can lead to depression, it can depress the immune system, and it can decrease life expectancy. So when we're deciding on interventions, we have to first distinguish what the pain goals are going to be based on the patient's care pathway. In consultation with the patient and the family, the caregivers need to explain the different pain pathways and what the goals of each of them are. And in the recovery pathway, where we need the patient's participation in order to promote their recovery, a level of consciousness trumps pain.
Complications of pain in treatment of pain. Increased incidence of adverse events result in our effort to eliminate pain. We get a lot of patients with altered level of consciousness, can progress to difficulty in swallowing, which can progress to airway issues, respiratory insufficiency, as well as atelectasis, aspiration, and pneumonia, hypotension, or it can be as simple as just weakness and failure to participate in physical therapy. In January of 2001, JCAHO required all hospitals to ensure that pain would be required or be assessed in all patients. Pain was treated in accordance with the guidelines developed by the National Comprehensive Cancer Network. And since that time, the incidence of opiate-associated adverse drug reactions and oversedation has increased by 150%. The incidence of opiate-associated respiratory failure since that time has increased by 200%. In 2002, opiates accounted for 2.4% of all medication errors, exceeding any other class of medications, and it increased from 9.5% in the preceding year. 94% of patients exhibited a reduced level of consciousness before experiencing adverse drug reactions, so it wasn't as though we didn't see it coming. This data was presented at the International Symposium by Dr. Hector Villa in 2005, and he is chief of anesthesia at the Lee Moffitt Center in Tampa, Florida. This is becoming an increasing problem, and this is why we added level of consciousness as the next vital sign. We feel that it's very important to attempt to control pain. Always, always, we want to eliminate suffering. But as Sue has explained, it may not be possible to eliminate all pain. And the last thing we need is to eliminate pain and put the patient in the intensive care unit on a ventilator with aspiration. We've not done the patient a favor. And this is what is happening as a result of the pendulum having swung so far on the fifth vital sign. We think that adding the sixth vital sign as level of consciousness will help balance out the benefit risk of pain treatment balanced with level of consciousness. Normal level of consciousness would include orientation times 4 to person, place, time, and situation. And if you expand what we commonly think of as oriented times 3 to 4, if the patient really is not familiar that they're actually in a hospital or why, and they're not clear about their situation, but everything else is there, they still have subtle alterations that are important to note. Level of consciousness can progress through 2 routes. Generally, it starts with anxiety, but in some patients, depending upon the cause, it will go on to confusion, agitation, and delirium. So you have a patient who's kind of ramping up. And the causes of somebody who has anxiety that then ramps up are very different than the causes of somebody who has anxiety and they ramp down. They go through anxiety, apathy, lethargy, stupor, and coma. And it's important for you to ascertain, as somebody's level of consciousness is getting altered, which of those 2 algorithms or which of those 2 pathways are they following. This can be assessed also by the Glasgow Coma Scale, which is an objective measurement, and we're going to talk a little bit about that. The best eye-opening verbal response or motor that a patient can give you, if they're normal, will add up to 15. So if you open your eyes spontaneously, verbally your speech is normal and you're oriented and you follow commands with your extremities, you get a 15. If you do none of those, you get a 3, and anything in between is abnormal. Well, anything less than 15 is abnormal. Anything in between is graded depending upon which of those responses. And I'm not going to go through it, but this is an important assessment tool in terms of level of consciousness. And if you call up a physician and tell them that their Glasgow Coma Scale has dropped from 14 to 8, they may ask you a lot of questions about what's going on with the patient, but that's very useful information. And a mnemonic that we were all taught in medical school is a Glasgow Coma Scale of 8, you intubate, because it means their level of consciousness is down to the extent they can't protect their airway, and they have to be intubated not to support respiration, but to support their airway and reduce aspiration. So sepsis, significant electrolyte or glucose or renal or hepatic abnormalities or dysfunction can give rise to either. You can go on from anxiety to delirium or anxiety to coma, depending upon the severity of the abnormality. However, generally hypoperfusion progresses from agitation to coma, along with hypercapnia, oversedation, and problems in the brain, increased intracranial pressure, whereas hypoxia, sedative withdrawal, toxic drug ingestion, or psychotic break generally progresses from anxiety to delirium. And knowing the difference between the two will help you start to look at, well, am I giving the patient a medication that's causing delirium? Or am I giving the patient a medication that's causing stupor? They're going to be very different medications. One may be Reglan that's causing delirium. The other may be morphine that's causing stupor. An altered level of consciousness obviously can interfere with the respiratory drive, effort, swallowing, and airway protection, and may signify a generalized clinical process, such as shock, sepsis, or impending respiratory failure. A thorough assessment in the diagnosis and cause in the change of the level of consciousness includes a focused neuroexam plus the Glasgow Coma Scale. And I want to talk to you about a focused neuroexam. It's not complicated. Do both pupils look the same, and do they react the same? Do they move their extremities equally and well? That's it. That's the only focused neural exam you need to do, plus the Glasgow Coma Scale. Because if there's no asymmetry in the pupils and the react, and there's no asymmetry in the motor, then there is some generalized systemic problem that we've talked about that's causing their altered level of consciousness. Whereas if there is a focal finding of a pupil on one side or an arm on the other side that's not moving, then you can be pretty sure that this is not a generalized process due to drugs or due to uremia or liver failure, but this is a focal process going on in the brain. So a focused neuroexam looking at the extremities and looking at the pupils and the Glasgow Coma Scale will give you a very clear picture as to what's going on with the decreased level of consciousness. And the physician is going to want to know that information when you call them and say, Mrs. Jones, who was feeding herself, now is very poorly responsive. You need to look at the medication record. You may be checking blood gases, electrolytes, and for sure, you're going to look at the other 9 signs of vitality. Airway and respiratory support are going to include, in addition to administering oxygen, is always make sure that you can use a nasal airway or an oral airway if, in fact, you determine that the patient is not keeping their airway open and they're snoring and they're spitting and they're sputtering. You may progress to BiPAP or intubation. It's important to support the patient hemodynamically if you have evidence of hyperperfusion and hypotension. You're obviously going to hold medications that may be contributing to this, such as sedatives and narcotics. And if you think it's due to a sedative and or narcotic, you're going to be administering the reversal agent, such as Narcan or Romazicon.
Oxygen saturation. Normal oxygen saturation is 94 to 100%, and it's considered significantly abnormal below 90%. Oxygen saturation actually reflects the percent of heme binding sites that are saturated with oxygen. Oxygen content is a little bit different. It reflects the saturation and the amount of hemoglobin with the heme binding sites. So there's 1.34 milliliters of oxygen in every 100 cc's or milliliters of blood at 100% hemoglobin saturation. So the oxygen content can be calculated taking the percent of saturation times the hemoglobin times 1.34. And we have a calculation down here at the bottom showing in a patient with 95% oxygen saturation with the hemoglobin of 14, times 1.34 has 17.8 milliliters of oxygen per 100 milliliters of blood. We measure oxygen saturation using a pulse oximeter. This can be difficult in patients that have poor circulation in the extremities. We can get really inaccurate readings. A bright external light in the patient's room can interfere with the pulse oximeter reading, so it's necessary sometimes to put that extremity under a blanket to cut out the ambient light so it doesn't bleed out the reading. It can also be inaccurate with carbon monoxide poisoning because you get false high readings because these heme binding sites are bound, but they're not bound with oxygen. It's important to check the pulse oximeter waveform in order to determine if you're getting an accurate reading. A flattened waveform will reflect poor perfusion and not give an accurate saturation measurement. And one way you can determine this is to see what the heart rate reading you're getting from the pulse oximeter waveform, how that correlates with the heart rate that you're getting from the cardiac monitor. If they don't match, or if they're not between 4 to 5 beats, then you're not getting an accurate pulse oximeter waveform, and you need to work with that and maybe place it a little more central on the patient. Sometimes an earlobe works better than a farther out extremity. The physiologic significance of hypoxemia is that it leads to anaerobic metabolism at the tissue level. And we can measure this when we draw lactic acid levels on patients because there's an increased lactic acid production from this anaerobic metabolism. It also decreases the patient's energy stores in the form of ATP, and it decreases their energy production. So hypoxia leads to multi-organ dysfunction and hypoxic shock. Hypoxia is an important and potentially avoidable cause of morbidity and mortality in our hospitals. It rapidly leads to a deterioration in the patient's level of consciousness, a loss of their respiratory and cardiovascular compensation, instability of their cardiovascular system, and can quite rapidly lead to a respiratory and cardiac arrest if it's not assessed and identified early. Some interventions is to be sure that you're properly placing the pulse oximeter monitor to begin with, and then verifying by evaluating the waveform on the monitor that you're getting an accurate reading and you're not led into a false sense of security. Decreasing the motion of the extremity where the probe is placed will help with artifact. Reducing the ambient light in the room to promote an accurate reading. Removing nail polish in the extremity where you're trying to monitor the pulse oximeter. And then checking the ABG if necessary to correlate the reading that you're getting with the true saturation that you're getting from the blood gas.
Hypoxia kills and hypercapnia does not. So I don't worry about CO2 retention acutely, but I get very concerned about hypoxia acutely. We're going to address this obviously with administering a supplemental oxygen, not being too terribly concerned about what's happening with the CO2 acutely. We may progress from a nasal cannula and suctioning and opening up the airway and a nasal or oral trumpet and an oral airway. We may go to a 100% rebreather, or we may use a Veni mask. I want to introduce the concept of a 100% high flow mask because 100% rebreather is a misnomer. When you are on a 100% rebreather, you have 15 liters of oxygen coming out of the wall into that mask with a bag. That bag is not a tight seal. It doesn't truly collapse during inspiration. And so most of the time when people are short of breath, they have peak inspiratory flows of 50 liters a minute. You've got 15 liters coming out of the wall. The bag is not collapsing, and therefore the amount of room air that are in training is 2 or 3 times the amount of oxygen you're administering. So the best you're going to get is 30 or 40 or 50% oxygen with, quote, 100% rebreather. So it's called a 100% rebreather. I can't change the name. It should be called I'm not sure what it should be called. But if you want to give 100% oxygen by mask and you don't want to create a tight seal with BiPAP or intubate the patient, your only choice is to deliver high flow. So you've got to deliver 50 liters a minute to the mask to be able to keep up with the patient's peak inspiratory flow during inspiration. The only way that you can do that is to bleed 2 oxygen meters through large tubing into the side of the mask. And if the patient's hair is not blowing back like somebody on a motorcycle without a helmet, they're not getting 100% oxygen. Okay? It drives me nuts. I'll go in and I'll say, turn up the oxygen. So you get up to 5 liters. If I can't hear it, they're not getting enough. I go right up, and even though it's being administered by the nose, I'll crank it right up to 15 liters. Do anything while you're trying to mobilize the resources. BiPAP, of course, is a very nice alternative to increase the oxygen and support respiration. And if none of these work, you're going to get an endotracheal tube and a ventilator.
All right, urine output is the next sign of vitality we're going to discuss. And really, urine output's our window to perfusion of the abdominal compartment. The kidneys are really the only organ in the abdomen that we can assess as far as how well they're being perfused. The other organs, the gallbladder, the pancreas, the colon, the small bowel, really don't give off signals until they're in a necrotic state or close to it. So it's important that we assess the kidneys, and we'll discuss in a few more slides why that's really important. Because if they start showing symptoms of problems, we know we can expect problems with some of the other organs as well. Normal urine output is 25 to 30 cc's per hour, or 0.5 cc's per kilogram per hour. Abnormal is less than 25 cc's per hour for 2 consecutive hours. But we know that patients on the floor aren't being monitored every 2 hours for the urine output. So a total of less than 500 cc's in 24 hours is lower than normal and should be addressed. With measuring urine output, it's important that the patient be educated that we are monitoring their urine output and that they need to save that and not throw that little hat away. With a patient with a Foley catheter, it's important to note that there aren't kinks in the tubing, that the collection bag isn't above the patient's kidneys. And sometimes that happens just when the patients get into bed. You throw that up there on the bed just to get them back in, but we don't remember to put it down and let gravity do its work. And so sometimes it just doesn't empty completely, and we're assessing it and not realizing that we have kinks or the bag just isn't low enough. In the incontinent patient, it may be necessary to weigh diapers in order to get an accurate I&O. The minimal expected urine output in patients is 200 cc's in 8 hours or 300 cc's in 12 hours, although we know this can be variable for patients who are dialysis patients.
The urine output is a function of the renal arterial blood flow. In the order of abdominal perfusion with low blood pressure, the kidneys are actually the last organs to drop off in terms of function as interabdominal blood pressure falls and interabdominal perfusion falls. The very first organ that drops offline is the gallbladder. Now think about this. The patient hasn't eaten, so the gallbladder is big. The cystic artery is the smallest in-organ artery in the body. There is no collateral circulation to the gallbladder. So now you have a situation in which you have a distended organ. That increases the wall tension. When you have increased wall tension, you actually need higher pressure to perfuse. But now we have low pressure. We have a single tinal artery and no collateral circulation. It's no wonder that when somebody gets oliguric and hypotensive, that the gallbladder is a problem down the road. Now, it can be a transient problem, or they can lead to acalculous cholecystitis, and it needs to come out. But it is the most vulnerable organ in the abdomen to any hypoperfusion. Next is the colon, and it's not uncommon for us to see ischemic bowel. Now, it may reverse and not require surgery. Frequently it does, and we get a resection. Small bowel is next, and it's not uncommon for a patient who's been significantly hypotensive to develop problems. For sure, they have a prolonged ileus. If bowel heals, it's okay. Sometimes it doesn't, and you have to resect dead segments. The liver, we see elevation in the transaminases. Most of the time the liver will recover, but if you have somebody with pre-existing liver disease, they don't have as much as they need to begin with. You have an episode of shock, you've lost a few more liver cells, it may be enough to push them over the edge. So if the kidneys aren't being perfused, you can be certain that all other interabdominal organs are being hypoperfused. The kidneys receive approximately 25% of the cardiac output. This is not because they need oxygen. This is because their primary job is to filter the blood. So they're receiving a disproportionate amount of cardiac output based on their metabolic demand. It's their filtration function that requires this high cardiac output. Therefore, the oxygen coming out of the kidney is much higher than any other organ because it's not extracting very much, because it's getting a high blood flow compared to the demand of oxygen. This becomes important when we get on to the last vital sign or sign of vitality, which is central venous oxygen saturation. And we're going to talk about how this high oxygen content coming from the abdomen in this situation influences the central venous oxygen saturation. If the urine output is low, we need to review, is this a prerenal issue? i.e., are we not getting enough blood to the kidney? And we'll go through what the prerenal issues are. Or is this a postrenal problem? Does the patient have BPH and they can't pee and their bladder's getting distended, or are they on some drugs that prevent bladder emptying, anticholinergics? So if we review the volume status, the cardiac output, the vascular resistance, which we have a sense as to how to do that, and we look at the volume status and the cardiac output and vascular resistance, and we say, you know what, it doesn't look like this patient has a prerenal issue, and I've bladder scanned them and the bladder's not distended and they don't have BPH and whatever, then we're starting to focus on, is this a primary renal problem that's developing? What's the gentamicin level? Are they getting vancomycin? Are we giving them some drug that's affecting the kidney? Or is this somebody that had pre-existing renal disease and is progressing for some reason? Is their blood pressure an issue? So it's important for you to go to this assessment, so as the urine output drops off, you will have wanted to do this. And then as you communicate with other clinicians, you may not be right. None of us are right most of the time. But if you thought it through and you say, this is my best educated opinion as to what's going on with this patient, that helps the other person. You've done, a good part of the work.
Capillary refill time is our next sign of vitality. Normal is less than or equal to 2 seconds, and abnormal is greater than 3 seconds. And the way we assess this, well, we actually have a couple ways we can assess it. We can either push on the patient's pad underneath their finger until it blanches and then watch it refill and count that time. Or we can even use the palm of the patient's hand and push on it, let it blanch, and then refill it. Mine's probably long. Or we can do what's illustrated here using the infant's heel. And you can see it depress and then blanch and then come back to a normal color in less than or equal to 2 seconds. Some things that can cause a prolonged capillary refill time can be a low cardiac output, also a cold environment, vasospasm, or arterial occlusive disease. If this capillary refill time is prolonged, it either indicates an inadequate pressure or flow to perfuse capillary bed and/or cool extremities, and/or primary peripheral vascular problems such as peripheral vascular disease or conditions such as Raynaud's.
With Raynaud's being spasm of the blood vessels induced by cold, I have Raynaud's myself, and when I get my hands cold, they will decrease circulation and my capillary time will be fine, but the rest of my organs, I think, are being perfused.
Increased capillary refill time is due to a decrease in tissue perfusion. And you need to assess, again, the patient's volume status, their pump status, whether the patient is displaying symptoms of sepsis, if the patient has a known peripheral vascular disease, or if the patient is hypothermic.
I need to just give you a case example here. First of all, I think capillary refill is a lost art. I don't think doctors do it at all. And I think that nurses have, maybe some of them have stopped doing it, although you guys are the best. And I started doing capillary refill again about 3 or 4 years ago because I said, it really is a very simple test. It's, it's like high benefit, low risk, no brainer, doesn't take any time. And it helps. It helps me with the patient. And so I had the luxury of having my son, who was in medical school at the time, do a critical care rotation with me. So Christian and I are going around in the hospital, and the ER calls me emergently, and we said, we've got this patient. He came in, he has syncope, he's paralyzed on one side, and he looks pretty sick. By the time we got down there, he was waking up, he was starting to move his weak extremity. He was able to talk to us. He couldn't tell us what happened in terms of the syncope. His blood pressure was okay. Foley catheter had been put in. We didn't have time to measure hourly, but there was urine. We didn't have a blood gas yet. He wasn't tachycardic. He wasn't hypotensive. He didn't look all that tachypnic to me, although I must admit I do not know what his respiratory rate was. And I did a capillary refill. It was 7 seconds. I looked at Christian and I said, Christian, I don't know what's wrong with this guy, but there's something wrong with this guy. 10 minutes later, he coded. We put a transducer probe on his heart. He had an ejection fraction of 5 to 10%. In retrospect, of course, the troponins came back positive. The 12-lead EKG hadn't been done yet. What had happened is he had fibrillated or gone into VTAC, had cerebral ischemia, had asymmetric carotid disease. So he produced ischemia more on one side of the brain than the other from his low cardiac output or no cardiac output, spontaneously converted his rhythm back to sinus, got his blood pressure back, started perfusing his brain. The only thing that told me that this guy was in cardiogenic shock, because I didn't have the lab back, hadn't had time, was the capillary refill. And I don't think Christian will ever forget this. I mean, he's an intern doing capillary refills on every patient.
So a significant change in capillary refill time or significant increase in capillary refill time should trigger an immediate assessment of the other signs of vitality. Reviewing the patient's volume status, cardiac function, vascular tone, and then reporting the findings of this assessment to the physician and anticipating fluid bolus orders.
Central venous oxygen saturation is a poor man's way to get an idea of the oxygen delivery to the tissues. The rich man's way is to put a pulmonary artery catheter in, measure the cardiac output, and have all the numbers. And you can be fairly confident as to what the oxygen delivery is to the tissues. But it's very invasive, it's expensive, and it's frequently not needed. There are situations in which it has value. But many patients who are sick have central lines in. If you have a central line in a patient, drawing a gas out of that central line, if it's above the diaphragm, that is, if this tip of the catheter is near the right atrium, you can get the saturation of the venous blood. So you can draw it from a pulmonary artery and get really central blood, or you can draw it from the right atrium, which is not completely well mixed, but it's mixed pretty well so that the blood from the lower part of the body and the blood from the upper part of the body are mixed, and you're getting an average of the tissue perfusion or extraction. Normally, we extract about 25% of the oxygen from the blood that goes past the tissue beds. In aggregate, the kidneys extract less, the brain extracts more, but in aggregate, if you take all the organs together, the average is 25% extraction. So if you're 95% saturated on the arterial side, 25 from 95 is 70. So the saturation on the venous side normally is 70.
To reiterate, the blood that we're sampling for the central venous oxygenation is blood that's traveled out to the tissues, dropped off its oxygen supply, and is now returning deoxygenated to the right atrium. Because we have so many more patients on the med-surg units now with multi-med catheters or central lines, this is one more tool we can use to assess the patient's tissue oxygenation.
If the things that can affect saturation on the venous side are stable, that is, if our hemoglobin is not dropping, and this slide is actually pointing out the reverse, which is that if you have a drop in the saturation of less than 70, it could be due to a drop in hemoglobin and not a cardiac output. It could be due to a drop on the arterial side. It could be due to the fact that the patient's seizing or has a high fever or is agitated and moving around in bed and is running the marathon. Or it could be due to a drop in cardiac output. So when you see a drop in central venous oxygen saturation, you have to go through the differential. Has my hemoglobin dropped? Has my arterial oxygenation dropped? Has my O2 consumption gone up clinically with significant fever or motor activity? If the answer is no, then we know that the ScVO2 is directly proportional to the cardiac output. So as it goes down, our cardiac output is dropping. As it goes up, our cardiac output and oxygen delivery to the tissues is going up. Again, we have to talk a little bit about content because I'm going to give you some examples to point out graphically to understand this concept more. But to do that, you have to understand that the content on the venous side is very similar to the content on the arterial side in regarding how you calculate it. It's identical. So we know that normally you're saturated 70% on the venous side. If you've got a hemoglobin, in this particular example, I'm not using the hemoglobin of 14 that Sue did in her example of arterial content, because most of our patients are anemic and run hemoglobins of around 10 in the hospital. But if you had a hemoglobin of 14, it would be 70% times 14 times 1.34, and your content, instead of being 9.4, would be 25% of 17.8, which is what she got on the arterial side. So here is an example where oxygen delivery and oxygen consumption are in balance. We've got a hemoglobin of 10, as you see on the top. This is a person who has an adequate normal cardiac output. And you can see our content on the arterial side, instead of being 17.8, is 12.8 because we're anemic. But we're 95% saturated. If we transfuse the patient 4 units of blood, the content would go up to the 17.8. We're extracting 25% oxygen. So we extract 3.4 milliliters of oxygen per minute. And 3.4 minus 12.8 is 9.4, and if you divided 12.8 into 9.4, that'd be 70%. So that's how you can visualize O2 extraction from a content on the arterial side will give you a venous content that is 70% of the arterial side, or 70% of the total, with 25% extraction. So that's how the body has this normal central venous oxygen saturation of 70%. Everybody who starts to exercise will preserve their central venous oxygen saturation. So as you start to increase your metabolic demand, you won't extract more. What you'll do is increase your cardiac output, keep your extraction the same, and your central venous oxygen saturation will stay 70, but you'll double your cardiac output, double your delivery, and your extraction will stay 25%. But you'll still extract 3.4 milliliters per unit time, but you've got so many more liters going by per minute. Okay? Per 100 mLs, not per unit time. I misspoke. Here's a situation we don't really care about too much, but it's an example of a very high cardiac output. Maybe somebody who has an AV shunt, somebody with liver disease, who has a lot of AV fistulas in their body, or maybe somebody who has an AV fistula on dialysis. So that blood's going from the arterial to venous side, and no oxygen is being extracted, right? Mm-hmm. So that's a shunt. So now we're extracting less than 25% because of our fistular shunt, and we're only extracting 2.5 milliliters of blood, increases our venous content to 10.3, which is 76%. So now our saturation's gone from a normal of 70 up to 76 because we have higher than normal delivery with less than normal extraction. This is the situation we're most concerned about. This is the clinical situation in which we know that this vital sign has dropped mortality from 46% to 30% in the emergency room in Detroit General Hospital, published in the New England Journal of Medicine in 2000 by Manny Rivers, early goal-directed therapy, by adding central venous oxygen saturation to the resuscitation of septic patients, severely septic patients in his emergency room. He was able to drop the mortality 16%. Huge. What this tells us is this vital sign tells us something that the other vital signs don't tell us right away. Now, you might figure it out with the other vital signs over time, but this is very good information, very objective information, and if you have a central venous oxygen saturation that is substantially below 70, and it's not due to a drop in hemoglobin, it's not due to the fact that your arterial oxygenation has fallen off, it's not due to the fact that you're seizing and have incredible demand, it is due to the fact that your cardiac output has dropped. And what's happened is even though you're 95% saturated on the venous side, your cardiac output's fallen dramatically, and you're having to increase extraction to try to meet tissue needs. And you're desaturated on the venous side. Now, what's the problem with this, Dr. Sabat? Because you're extracting more, you're still meeting the needs. There's a limit, because as you extract more, the partial pressure of oxygen falls to such a low level that even though there's still oxygen in the blood, there's no pressure to push it into the mitochondria. So we can't desaturate our blood much below 50%. We start getting below 50%, the PO2 is so low, our PO2 is in the 20s or 18, and it's not enough pressure to push oxygen into the mitochondria. So the central venous oxygen saturation is telling us you're getting down to a PO2 at the tissue level that's so low that any further drop in the tissues are going to get anoxic.
So in summary, when we're assessing the SaO2, and we've already looked at the hemoglobin, the temperature, the work of breathing, and muscle activity, and found that these are all unchanged and are acceptable, and we have a low level, then we need to attribute that to inadequate cardiac output and place the call, communicating our assessment. After assessing the other 9 signs of vitality and anticipating this communication phone call, we need to be sure that we have all this other information ready, because this is what the physician will want to know. Does the patient exhibit an increase in the work of breathing or muscle activity? Is this a patient who is hypothermic and is now shivering, which will increase the metabolic rate by 100%? What's the patient's volume status, and what is the patient's cardiac function as we've assessed it? So in conclusion, if you see significant abnormalities in the first five vital signs that we're used to assessing, that should trigger a complete 10 signs of vitality assessment, including the level of consciousness, the oxygen saturation, urine output, capillary refill, and SCVO2. And then based on this assessment that involves the 10 signs of vitality, you would then anticipate and implement either respiratory and airway support by protocol, volume or cardiovascular support by protocol, SBAR communication with the physician, neurologic support, whether that would be a reversal agent if the patient's received too much of a narcotic or a sedative, or a change in the patient's medications if those are antihypertensive beta blockers, etc.
I'd like to add at this point, before our concluding comment that Sue has, is that we have done variations of implementing this kind of education in other places. Not this comprehensive, but something on the same theme. And we started out with the EMS people and the nurses. And we had a patient who was in the field who was complaining of pain in her feet, lightheaded, blood pressure was about 80. And the EMT recognized that this patient was critically ill and called a shock alert, which was the program that existed at the institution I was at. The patient was transported to the emergency room, and after a liter or so of fluid, the blood pressure was 110. The patient was sitting up talking, still feeling anxious, tachypnic, and lightheaded, and still had pain in her feet. But she looked, eyeballed, you walked past, sitting up in bed, interacting with people, she looked pretty good. Because the shock alert was called, that required the ED physician and the intensivist on call to go in and assess the patient and determine if, in fact, the patient was in shock. The ED physician came out who was experienced, and the intensivist who trained at a famous medical center of one of the best critical care programs in the country came out and said, this patient is not in shock. Tachypnic. The reason she had pain in her feet is she didn't have any capillary refill in them. Okay? She had been hypotensive but wasn't hypotensive anymore, and altered mental status. By the 9 signs or 10 signs of vitality, she had 3 or 4 of them that were really a problem. I looked at my partner and said, why don't you just go through the drill? Make sure this patient's not in shock. Comment was, patient's not in shock. Both people left. Patient got admitted to primary care physician with a diagnosis of mild hypovolemia. Patient gets readmitted at 2 o'clock in the morning to the ICU, moribund, puerperal fulminans, acute renal failure, ARDS, DIC. When they went back and checked the lab, because the lab had beat the doctors from calling off the shock alert and had drawn all of the appropriate blood work, including a lactic acid, the lactic acid was 7. Who recognized that the patient was in shock? Not the experienced intensivist trained at one of the best programs in the country. Not the emergency room physician. Not the ER nurse. The EMT who graduated from the community college. This stuff is simple stuff, but nobody's doing it.
So, proficiency in the 10 signs of vitality and SBAR communication will decrease morbidity, decrease mortality, and decrease code blues in our hospitals.
We wish to thank you very much.